7 a.m. We have quorum. Let's come to order. Any members of the public online or here in office with us, here in the meeting room with us, would like to address the board? Hearing none. I get a motion to approve last month's meeting minutes. So moved. Okay. Any comments about the minutes? What's all done? All in favor of the motion? Aye. Opposed, same sign. Minutes are approved. John, you're up.
All right. Good morning, everybody. Thanks for the response. Well, 2 weeks ago now, we celebrated National Public Health Week here at RiverStone Health. And the theme of National Public Health Week was Ready, Set, Action. I had the idea to turn some of our public health staff into movie stars. But we had some other fun and did some other things instead to celebrate. And so I shared the thank you message with our team, but also more importantly with you as our board members. Thank you for supporting us. Thanks for supporting your county health department and everybody at RiverStone Health. We couldn't do what we do without all of you helping us down this path. So thank you. Despite any other misinformation attempts that have been out there, the Colonial is now down and the deal is a private real estate transaction between the estate and trust and the Yellowstone Health Partnership. We will be closing on the property and finalizing that purchase as soon as Wednesday of next week. So by the end of next week, that will be closed on and done.
Congratulations.
Thank you. Thank you. And again, no, if anybody asks, we can be sure to tell them no public money was used to secure that building, to demolish that building, or to purchase that property. This was all a private transaction that happened between the estate and YHP, and we'll be putting it behind us next week. And then moving on and saying, hey, what do we want to build in that space? What does the future of a community resiliency center, housing services look like for the south side of Billings? And so we'll be going through our strategic planning process and engaging all of you in that process as we go forward over the next couple months. And so we'll have an opportunity to figure out what do we want to see there on the court in the future.
Car wash.
Yeah, it's good revenue. Good revenue. Isn't that what I said last month? To build some revenue for our coffers and build what we want. It'll be a car wash, self-storage, smoke shop with a casino. Yeah. It's
23rd.
City of Billings zoning supports all of those. In more positive news, we received official word from Congressman Downing last week that he is going to forward and support our request for congressionally directed spending to build a new clinic in Joliet. And so that will be moving forward in the appropriations process federally. And yesterday or the day before, we received word from Senator Sheehy's office that he has also put forward our request to the Appropriations Committee. So hopefully we'll hear something in the fall, September, October timeline, assuming the wheels of government operate in Washington. And we'll hear something by late fall on whether or not that's all been put into a bill and will be approved. We had the opportunity to recognize some amazing volunteers. This was Volunteer Appreciation Month. And at this month's banquet, we got to honor 2 Marines. And Art Lyle from our clinic board and Pete Tim, who is a volunteer within our hospice program, both Marine Corps veterans who continue to serve their country. And so we honored them this past week. And Art was essential to getting an AED placed at the Huntley seniors out there and making sure that they have access to an AED and folks that know how to use it. So our warden clinic staff helped train them, get them a place to store it securely, and are going to do preventive maintenance on it for them so that that stays there. And Art's just been a long time volunteer for us. So we're proud to honor both of them. And then last week we had the Confluence Public Health Conference, the annual meeting of the Montana Public Health Association, the Montana Environmental Health Association, and the Association of Montana Public Health Officials. So that three organizations came together at the Billings Hotel and Convention Center, along with folks from the state and DPHHS, and some other folks from a couple other states. And we had a great conference talking about, all things public health, how we can do better, how we can create a stronger public health system. And our staff presented, we had staff present on behavioral health and crisis coalitions, as well as on our lawful efforts to regulate kratom in food supply. So we'll continue to do that work. On that kratom note, last week we had the opportunity to provide the first package of 4 to 5 establishments that are not compliant at this time with the Montana Food Code and FDA regulations as it relates to selling kratom as a non-approved dietary supplement and unapproved food additive in conventional food and beverage. And so we met with the county attorney's office to hand that off, and that will be going forward with filing an injunction to compel those folks to follow the law. The laws are only as good as the folks that enforce them, and so now it's enforcement time. We've done our due diligence to educate and train food establishments on what they can and cannot sell to keep our food supply safe. And so now it's in the hands of county attorney and the judicial system. And then to finish up, the Montana DPHHS respiratory dashboard is there for your review real quick. Flu continues to decline, fortunately. We don't see as many positive influenza cases across the state. However, RSV is continuing to spike. And so while the light blue number of tests being performed is declining, the percent positive is increasing pretty dramatically. And so RSV remains out there, probably remains the top upper respiratory illness at this time. And as a result, BPHHS has recommended that through the end of this month, we don't know if this is going to be extended or not, but through the end of this month, RSV immunization treatment is recommended for newborns. They've extended the vaccine timeline. So we'll continue to monitor that and see what happens. And then on an additional note, we had well, there were certainly fireworks yesterday, but pre-fireworks, we had a really good meeting a couple weeks ago with our community behavioral health work group, and not focused on Laurel, not focused on the state's efforts, but focused on behavioral health as a system and where the gaps are. So going all the way back to the gap analysis that this work group performed at the very beginning. Many of those gaps still exist. And this group met to continue to say, wherever the heck this thing ends up in the state of Montana, this thing being the forensic behavioral health facility, these are all the issues that we still have as a community and as a state to address if we're going to make any movement and difference in behavioral health care and in the continuum going forward. And so we're remaining focused on fixing that, fixing the continuum, figuring out how do we write common sense legislation? How do we create some staffing pipelines? How do we create some alignment here within Yellowstone County and Billings, within the service providers we have here, so that we can all do better and take care of people. And we demand the information that we need from the state when folks are discharged, all the way to when we're reintegrating them into jobs and employment in our community. That's what we're focused on. And unfortunately, the state is trying to continue to use that against us. Instead of showing up professionally and listening to our community yesterday, they sent 2 lawyers just to listen and not answer questions. And I will leave it at that. I know more can be said, but it's not going how it ought to be going. If we're trying to get buy-in and create a solution in our community. Any questions or comments?
A quick question.
Yeah.
I was wondering if Megan was going to be here this morning.
He is online.
He's online. I'm not sure who the question should go to, Megan or Eric, but I see lots of talk, and I get questions about getting COVID vaccinations twice a year. And I wondered if there's what the recommendations are from the medical perspective and what I should tell people.
I'll let Megan answer from the potential medical perspective if she's hearing something different. But we were supposed to get a very well-written and well-studied COVID vaccine report out of the CDC this week. And the report was axed. It showed signs of really great beneficial outcomes from the COVID vaccine and some other clinical things that we were going to have discussions on, but nobody got to see it. So we're still waiting for that to be released. Dr. Littlefield, any comments?
No, that's what I was going to say. I think that we're still trying to I think we're still trying to figure out what the standard guidelines are. There has been some suggestions to get twice yearly vaccinations, specifically for high risk populations, but not for all adults. But as John mentioned, I think with some of the changes in the CDC and the guidelines that we have traditionally fallen back on and relied upon are coming from a variety of sources now rather than from one unified voice. So.
Other questions for John? Comments about the COVID vaccine?
I don't know what to tell people.
Yeah.
Which is unfortunate. Such disarray.
Yeah.
Thank you, Megan.
Megan, do you have other comments of your report for the month?
I didn't do a formal report. Most of what has been going on has been a continuation of my report last month. I will say that I think we had talked last month about really trying to pilot and push telehealth visits. We did some pilots we have done telehealth visits during a provider session where a provider is at clinic and they would see some patients who are at home via telehealth. But we have not formally had telehealth visits where we had a provider perhaps off-site or not in clinic doing a whole session of telehealth with patients who are, different sites. So we've piloted a couple of those sessions this month and they went really well. So now all we don't need a medical assistant to support that session. We have some administrative assistant who checks the patient in, verifies insurance, verifies their form, but then the rest of the visit is conducted with a provider, with just the provider and the patient. We worked out a few kinks. Those sessions went really well. We're looking forward to starting to implement some telehealth sessions into providers' schedules routinely, I believe starting in June. And so I think this is exciting. It's going to increase our access to our patients. It will decrease the burden on staffing demands in clinic. And I think we're really going to be able to meet a number of patient needs without them having to come into the clinic. So we're pretty excited about that. APP residency is actively recruiting. We actually have a number of applicants that we're starting to go through. I know that we have a report at the end, a new business to introduce all of our new residents for the MFMR residency program. So we look forward to sharing that information. And then I also mentioned last month that April is Child Abuse Prevention Month. Our CAC team has been involved in a variety of activities. You may have noticed the blue pinwheels on campus, and there are blue pinwheels on the courthouse green downtown. We participated in planting those a couple of Fridays ago, and I believe we have a presentation about the CAC at the end of this meeting as well too. So that's all I have for you.
Any questions for Megan this morning? Hearing none. Lionel, do we have a safety and quality?
We do, but I think that today I'm told that Bob will need to create a.
Yep, I'm ready, Lionel. Thank you. So we have continued our conversations with each of the service areas regarding their use of artificial intelligence. And this last meeting was the clinic team. And so Lauren Brown shared information. I'll touch on a few of the things. The dental area has not yet found that the AI capabilities within eClinicalWorks are of value in their workflow, but they're continuing to evaluate that. The pharmacy is much the same way. So much of the meeting focused on the clinic side. And we talked a little bit about how early adoption was a benefit to us in that we found out that there were some things that didn't work. So one example of that was our no-show predictor, and it was supposed to tell us who is not going to make it to their appointment, allow us to take proactive action to try to get them to their appointments. What we found is that our existing workflow still had better results than the automated AI version. So that led into a conversation about just the evolution of AI and how quickly things are changing, and that the no-show predictor of the past has been revised a number of times, and now we're looking at it again for another iteration to see if it has made enough improvement that brings value to the organization. So that's changing all the time. We talked about where we're using it most heavily. And so the areas where we're using it most heavily are, and jump in, Megan, it's some of the researching. So our providers, as they're looking up information, they're utilizing some of the resources that are available and now in an AI fashion. We're using it, of course, as a scribe during our sessions. So rather than writing down or typing information as the patient is presenting it, the AI scribe is listening and it's putting all of that information together into a format that goes into the electronic medical record. Feedback in some of our client surveys indicate that they like that. They feel like our providers are more engaged and that those sessions seem a bit more personal. So I think we're seeing some gain there. Yeah, Coach.
How do the providers like it?
I'll let Megan talk to how do the providers like.
We love it. We love it. Yeah, it really has. The AI scribe has really helped us to be able to focus on the patient that's there in front of us and not feel like we have to capture all of that information down in writing. And I think the other thing, and I shared this with the team when we presented at the meeting the other day, the other thing that I really think is helpful is the way it's able to summarize and create information that you can give to the patient when they leave on their after visit summary that really summarizes the visit in a succinct way and clearly outlines recommendations. And I think that that is a fantastic patient tool. And then the one other thing that that I spoke about when we talked about it at the meeting is you're actually able to create patient information content from one of the, most of us use a form called Open Evidence that has signed agreements with like the New England Journal and JAMA and a number of peer-reviewed journals, and I can put something in there. So I had a patient that was a child who was homeless and who was struggling with sleep. And, we have a typical handouts on sleep hygiene that we give out to parents that talk about sleep promotion. But in this particular child, they're couch surfing. So they do not, a lot of the typical sleep hygiene recommendations that you would give to someone who was housed with a stable, bed were not applicable to this patient. But I was able to put into my my AI, can you give me some instructions for a patient who's experiencing homelessness and is struggling with sleep, how to help support their child? And it curated this beautiful list of recommendations, which were some of the things that I had spoken about, but it curated this beautiful list that I was able to hand to the patient in real time. So providers love it. And I think patients do too.
And I think, one addition there, and Megan touched on it, is when we gather those resources, it comes from well-known and respected source versus we're not just going to Google and saying, hey, give me some recommendations for this particular case. So I think it really is providing a greater magnitude of accuracy in the data we're able to deliver almost in real time. So we were talking at the meeting that if Megan or the team had to go look up all this information, compile it, put it together on a document to give to the patient, it probably would have taken us days to do. Where in this case, we were able to gather that information, print it, and the patient left the meeting with that in hand. So really a great lift there. And the final piece would be, where are we going with some of this? So as we're talking about scribing, what comes next is that AI is listening to start orders. So I'm starting prescription orders. I'm starting lab orders so that the physician doesn't have to take the time to initiate that and search out all of the different items per se, but AI is starting that. So what the physician is going to do is just review the orders that have been created in that session and say, yep, I like these go forward, these we don't need. But again, the idea is that they are able to spend time with the patient and the situation versus all of the administrative functions of an office visit.
Questions for Bob or Megan? Pretty darn fascinating.
It's, I so reflect on when John and I school, you would sneak into the library late at night, look up things so that you didn't look stupid the next morning on rounds. And then the internet came along and you could have, the world's knowledge in your hand, but trying to search through it all was a challenge. And now you have this, which does all that for you. So what has happened in the last 40, 50 years is, in fact, the last 5 years,
Open evidence is it's like Chat GPT for medical providers. It's really,
And I can tell Lionel was much more conscientious in school than I was.
Jim?
Yeah.
So I doctor here, and my last exam, my provider printed out my note from our exam, showed me what I needed to do, showed me, when we went through the note together, I understood exactly what he was trying to communicate to me, and it was really helpful. As just an outside patient looking in to see how that process worked. And Lionel, I thought you were AI for a while.
I was.
I haven't seen you.
I was AW.
Stuart, I was thinking about, what did the programmer make a mistake? What's our liability in that situation? But
Well, I read the note, and that is a problem.
Yeah.
I don't know if you remember the times when people would send out emails that said dictated but not read. I don't know if you remember that time. That created a lot of liability, and there has been a lot of court decisions where AI has been utilized in briefing and court proceedings, and serious sanctions have been levied against law firms for relying upon AI. So you can't substitute or rely on that. So the provider still has an obligation to prove and is still responsible for the statements that are made within those notes.
still have some professional responsibility,
Absolutely.
that presentation.
Yeah. And I will say that's what we train our providers we don't allow everyone to use AI when they first come into the practice. So residents, for example, they aren't allowed to use the AI tools until it has been approved by the faculty that they're able to, manage writing the notes and thinking through the differential, and that they're not just relying on AI. But what we tell everyone is anything that is put in that note, whether that was something you pulled over from AI or pulled forward from a previous template, if you sign your name to that, you are saying that is what you believe. And so it is critical that while this makes our job a lot easier, it is critical that you review everything that is being produced by AI or in previous templates.
Thanks, Megan. That helps.
And Jim, that really is, again, back to the function of the governance committee that meets on these technologies, is to ensure we think about the impact of the patient and making sure that they have the appropriate consents to allow us to do that. We think about the providers that are delivering the care and how they need to interact with the technology so that ultimately the buck stops with them. And I know that Garth is really, really intentional in talking to our residents about that, and Megan in talking across the board of our clinical staff to make sure that, hey, you're still on the hook for this. All we're doing is helping you with some of the lift from the administrative gathering perspective. But I can't stress enough, and I know this came up in our safety and quality committees the last 3 times, was what do we do about governance? Because there is legitimate concern about what is the risk to the organization. And so we do take that as a condition of that group, is to make sure we're looking at all avenues of that.
Thanks. Michael, did you have a comment?
Oh, no, that's good. Thank you.
Other comments or questions about safety and quality report? Hearing none. We have meeting notes in there? Yep. Can I have a motion to accept the notes?
So moved.
Second. All in favor? Opposed, same sign. Hearing none. They are approved. Finance committee didn't meet, but I saw my trees budding out this morning. And I thought, that means it's probably budget time, isn't it? Any comment for the board?
Yeah, a couple comments. So we're in the thick of budgeting. I would say we're in a good place with a draft. Not good in the fact that we're at probably a negative $2 million bottom line right now, but good in the fact that it's pulled together. We'll have a draft budget brought to the board in the month of May for review. So really a few things that we're facing. Obviously, we've talked about 340B over and over again. That'll be an impact of about $350,000 to this next fiscal year. We're also facing a huge shift in Medicaid. We're not sure what to expect for that. We're not sure what we're going to see for that, but our best guess right now is about a 5% shift in our Medicaid payer. We've obviously incorporated some of that moving into self-pay, but there's a lot of question on what that will look like for us organizationally. Right now, with that 5% shift in Medicaid, we're facing about an $891,000 loss in revenue related to that. So also a big hurdle for us going into next year's budget. And then the final thing is just kind of anticipating a level mill levy from the county based on kind of what's going on with property taxes. And so those three things combined brought us to about a negative $2 million bottom line. One bright side, I think, for us organizationally is we've spent the last 2 months taking on a huge compensation project organizationally, essentially reviewing every single individual within the organization, reviewing their years of experience and getting everybody to an accurate weighting as far as it goes. And so we've taken all of the individuals, all of their years of experience, spread it across our normal salary guidelines to come up with salary increases for staff in this coming year. So similar to last year, are not anticipating doing a flat 2 or 3% or whatever it was done historically organizationally. Really looking at getting people moving through those different ranges within their wage classification organizationally. And so a huge lift, and honestly, I mean, something that we really are prioritizing organizationally is just getting better pay to all of the individuals within the organization. It's obviously something that's been a concern across the organization for many years. And so I feel like we're in a really good place to implement that. Just need to find the money, but we're working through that right now. Those salary increases across the organization for next fiscal year are budgeted about $1.3 million. And so, like I said, a huge project, and that feels really good to see that all come together and get accurate information across the organization. So I don't have all the answers right now. We'll have templates set out to managers within this week and just kind of work through each of those things that we're navigating as far as concerns and uncertainties in this next year's budget.
Does the 1.3 million in compensation increase get everybody into the range, the appropriate range for their
No.
class?
No, we've spread it. We're our budget this year, we're actually looking over a 5-year period just to be a little bit more proactive than we have historically. So our budget right now is going through fiscal year 30. And so we've taken what we have for those and spread, I mean, it's going to go over the next few years. If we do what we're doing this year for increases, spread it over the next few fiscal years, we'll still have a $500,000 gap in getting everybody to where they need to be within those ranges. So really taking a big chunk of it this year. It goes down significantly in the next couple of years and then kind of increases if we start including some cost of living in the following years. So it's a big lift, but we're in a good place to implement. Like I said, just need to,
Congratulations. I know that's been a lot of work, a big effort.
yeah, it's really been neat.
Does everyone understand the Medicaid issue, the Medicaid reimbursement issue? Or what would cause that? Explain, do a quick.
Probably best to have John
I
explain.
can hop in, sure. So there are about 4 things happening at once within the Montana Medicaid system right now. And so they're all happening at once. We're running down the road towards the brick wall of work requirements, a new primary care Montana patient attribution system, and the other impacts of Medicaid redetermination. And so there's yet to be any firm communication out to patients. But that many of them are getting letters, and they're getting multiple letters again from the state saying, hey, starting July 1st, we're going to implement work and community engagement requirements. Also starting July 1st, we're going to start this brand new Medicaid primary care Montana program, which will most likely change your primary care provider. If you're not savvy enough to make sure that RiverStone Health, or if you go to Intermountain or Billings Clinic, is your set primary care provider. And those notices have begun going out to patients. And so right now we are doing some targeted communication and outreach to folks saying, hey, don't get lost in the sauce. You know, we don't want what happened last time with Medicaid redetermination to impact you. This go round, if you're eligible, you're still eligible. Here's what you need to do. So what folks need to do right now, even if they're exempt from any of the new changes, they need to make sure that their contact information is updated with the state of Montana, that they have their latest address. They know, where you're living, what you're doing, where you're employed, all of those things, because they're going to do this the old-fashioned way through mail. And if your address with the state of Montana is incorrect, you may get, again, lost in this process. And then when you do get a letter from DPHHS, respond. Don't just toss it in the garbage and, oh, it got something from the state of Montana. Bring it into RiverStone, bring it to your medical provider, let them help you walk through this process. So that's all happening. The notification process is beginning. At the same time, the state was mandated by a bill passed in the legislature last session that they must go live by May 1st, June 1st, with a new community assister portal. And that community assister portal, the whole reason the legislation was written and we supported it as an entity was because it would enable our care coordinators within the clinic to sit down with a patient in front of them and help them upload in real time any documentation, their information, make sure that their information was correct and their status was okay in the portal. And then we could update their income information, their job information, their eligibility, etc. That hasn't happened yet. We don't know when that's going to happen. We've yet to hear from the state that is still planned to be rolled out on time. And then there are the positions that the state still needs to fill. Last time they were about 50% fill with the 60 plus staff that we need to add to manage this new Medicaid system. The non-red tape, non-bureaucracy administration at the state level has now decided we need to create more red tape and more bureaucracy in DPHHS. And so all of these things are happening at once, and there's a lack of communication and transparency like we've seen in other cases, and our patients are the ones who are going to suffer. And so we're trying to stay on top of that as much as possible so that we can help those folks that are eligible, are truly eligible, might not need to be on Medicaid long-term, like the majority of our Medicaid patients, if we can help them, but they're making it very difficult for us to help them effectively.
Questions or comments for John?
Well, mental health going forward is going to be very challenging because the state has already told the community mental health partners that there's going to be a decrease in reimbursement next year. And most of those are basically living kind of hand to mouth now. There's labor unrest at Warm Springs. There was a threatened walkout 2 weeks ago, and that didn't make the news. But, there's a ton of things going on, and you have the mental health prison in Laurel. They got appropriated $25 million. And now they're talking about they need another $40 million, and that's not appropriated. So that means that $40 million is going to have to come from somewhere else in the mental health program. It's going to be challenging to be able to provide any level of sustained services to people.
Yeah. The impacts of HR1, big beautiful bill, whether it's that specifically or whether it's the state's property tax reform and shrinking the tax base, thinking we had all of this excess revenue in our coffers. Well, now that just got wiped out, and so we went from a budget surplus to a budget deficit at the state level overnight. because of the tax changes at the federal level and across the state. And so we flipped it on its head. And so now the state is going to try to come up with $500 to $600 million this biennium. And a lot of the weight is going to be placed on DPHHS to find that money. And so they're going to try to find that through what Medicaid covers and doesn't cover. So there's a lot of conversation over the past couple of weeks about the doula program and whether that'll remain covered or not covered, whether dental care is going to be covered or uncovered. They're going to go now piece by piece within the coverages across Medicaid and add one more thing to the burden of patients who are just trying to survive. And so it's not going to be as bad as it was. I still remain optimistic. The last go round where we just had this bolus of folks removed at the end of the public health emergency. There are some protections built in. It's not all bad news. That redeterminations will happen on a rolling basis now, rather than all at once. And so if you were originally eligible in January, you'll have to redetermine in July and then redetermine the following. So every 6 months now, right? Instead of annually. I guess is as good as mine as to how many patients that will truly impact. We're guessing about 5% just based on what we know about our Medicaid population that we serve. Did I miss anything, Aaron?
Sorry, I was catching up with Kristen here. Did you mention that we added an insurance support person?
No. So we did, yeah, we are beefing up our care coordination team in an effort to help folks, meet people where they are when that portal, if and when it does ever go live, we'll be able to have an additional person on staff to help manage that and help folks when they come in. So.
And the property tax piece is no better because, we get certified values every year.
Yep.
And this year, for the first time ever, we got recertified values, so we sent out amended tax bills. And we have special districts, i.e. basically school districts and fire districts that, thought they were going to have this in revenue and now have this in revenue. It's a pretty ugly picture, actually. It's the bouncing ball. Nobody knows where, what we're going to have for revenue.
Okay, now you understand why bean counters are. So for happy news, let's go to public health policy. Brent.
As we have general policy updates, I think most of the topics been covered. Anybody want to add, John?
Yeah, no, we talked a lot about our policy priorities. The next meeting, first week of May, I'm going to give the policy committee our policy priority sheet for them to work through and say, no, check the box, we did that, or no, we need to keep monitoring this and try to get ourselves a good, concise policy agenda so that we can send that out to folks after the midterms. Once they get, we know who's running for which office to say, hey, local elected prospective leaders, here's our policy agenda for the upcoming session. Let us know where we find, synergies, and we're happy to work with you. So that'll be coming up at the next policy meeting. The only other thing that we covered, we began the conversation on public accommodations and inspection of public accommodations that are not hotels and resorts or motels and inns, but tourist homes, yes. And so I think Airbnbs, VRBOs, Right now in Yellowstone County, there's a small, very small percentage of those who have actually applied for licensure and are licensed. In places like Missoula and the Flathead, where there's a lot more tourist industry, they are mandated to be licensed and have to pay a fee and have to be inspected as public accommodations. And so the Public Policy Committee with Public Health is at the very beginning stages of looking at recommendations to manage tourist homes, Airbnbs, VRBOs here in our jurisdiction.
Yeah, at this point, we've decided not to make any changes. Status is kind of a complaint basis right now. So then we looked at the status of the Rural Health Transformation Grant update, and there are requests for proposals out now, which apparently will be responded to by hospitals. The opportunity to create what are called centers of excellence, and these will be centers, apparently independent establishments that will look at things as telemedicine, maybe increased use of mobile units, shared infrastructure, and other things. So that's an ongoing process in regard to the use of that money. And John kind of took my thing about the tourist home. Sorry, overstepped his bounds there, but and Kratom update has already been discussed. So, oh, and then the last thing, yeah, state immunization coalition update. There's a statewide coalition of various providers, institutions, trying to educate on vaccinations and combat, the forces that seem to be opposed to use of vaccinations. And pleased that for the third year in a row, the Public Health Policy Development Committee was voted the outstanding committee. We did it on meeting.
Okay.
Congratulations.
I gave myself like the Peace Prize. I do have one more update on policy. Just got I hope it's the final draft. Melissa Henderson, myself, folks at Confluence, and our public health group at the state, we have now drafted a bill that will go to the 27th session on kratom regulation. Not prohibition, not a ban, but regulation of the substance. And it maintains Montana Food Code and already established law, so it keeps it out of licensed food establishments. But it then goes down the line of setting age restrictions, concentration limits, where it can and cannot be sold, with proximity to schools and things like that, as well as creating regulatory authority. And in a budget crunch that the state is going to have, we try to give them a gift and create this as a revenue bill so that it would generate income for the state of Montana and not add to any regulatory burden. So we'll see where it goes. We have a couple sponsors lined up on the Republican side of the House and majority who will want to carry this. And so we'll see where it goes in the 2027 session.
Any other comments or questions about public health policy?
I just have on the rural health transformation money.
Yes.
Am I interpreting this correctly that it's only hospitals are going to get it?
No.
Okay.
FQHCs are baked into the package.
Okay.
So community health centers are baked in. The only health entities, so rural health clinics, PPS and our critical access hospitals, all explicitly baked into the proposal and the application. The only group that actually wasn't in anywhere was public health. And so I don't think that public health is excluded from receiving the funding. They just weren't explicitly mentioned, which is, the healthcare case, since everybody forgets about public health until they need it. And so we've been really good at the confluence perspective from a statewide level, DPHHS getting movement and momentum by advocating for, hey, don't forget your local health departments and the programs that we help operate, which one of you'll hear about in a couple minutes, to say we could use this funding too, to help improve rural health across the state. So FQs, school-based health centers are explicitly named. And so there are some things in there that we are absolutely targeting to go after either individually or as a group through the Montana Primary Care Association as FQs or clinics.
Isn't it getting close to the time for the first funding round or?
Yeah, it is. So the RFP went out the door for the centers of excellence. And so that, think MSU or or the Healthcare Foundation or the Hospital Association,
Okay,
who could be the keeper of the larger pot of money that then subgrants out to entities who are willing to play ball in the center of excellence model.
okay,
Eric?
Yep, that's what we know so far.
okay.
The only other thing is that they forecast, so the centers of excellence have a bunch of stuff, a bunch of buckets of money that fall under them that are going to kind of be released through healthcare entities participating in the centers of excellence. And so what MPCA at least is anticipating as some of the first money coming out of that will be funds released to organizations that agree to participate in stuff like data sharing and giving them their organization's information so that they can do some of the analysis that Brent was talking about to identify areas for possible efficiencies or overcapacitation or undercapacitation in certain areas of the state. So some of our FQHC partners around the state are pretty nervous right now that don't have good relationships with their hospital partners in their regions, because one of the stated purposes of these centers of excellence is to try and help the state with capacity planning. And some of them are a little concerned that it will turn into a fight between them and the hospitals about who's going to get to be the primary care provider in the region, which seems really silly, but you know how when resources start to get reallocated, the defenses start to come up. But so I don't think we have that problem here in Billings. So I don't think that's something that's going to hit home here, but that pot of money is somewhere in the ballpark of about 350,000. And then I think what I'm hearing is starting like probably next year, some of the more specific funding stuff like funding for mobile units or funding for school-based health centers will start to be pushed out.
For helping rural healthcare stay viable. I mean,
Yeah.
it sounds like it's going to be used for administrative stuff.
That's the unfortunate piece. And it's, buy stock in Deloitte if you have it, because the consultants are going to win the day on this across the country. And so when you take $150 billion out of the system and you replace it with a $50 billion hit check, and you call that an investment, you're really just creating a Hunger Games scenario where people are fighting over limited resources. And yeah, that's one way to create innovation when resources are scarce. But is it the best way? Time will tell.
Yeah. Other comments or questions related to public health? Hearing none, can I get a motion to accept the meeting notes? Second. All in favor? Opposed, same sign. They are accepted. Governance met last month to address a couple of issues. One is respect that we are all volunteers. Our pay is that breakfast that we get once a month. In lieu of compensation, we get that fine breakfast once a month. And it's appreciated, greatly appreciated by your peers, by the community, by the shareholders in Yellowstone City County Health Department. And it can't happen. These meetings can't happen without our attendance. So we had one of the committee chairs asked me if I wanted him to step aside because it had attendance issues for the last few months. So let me run it by governance and get some feedback. And we went through a lot of issues, talked through a lot of things, and felt very comfortable with the committee chair staying on point. And also with the board, we'll just take the opportunity to remind us all that it's important to make the meetings and participate, be engaged, get through the materials, the phone book once a month before we get here, and say thank you to everybody, because it does take time. The second thing we discussed was we've had the pleasure of public input at the last few meetings. Sort of surprised we don't have it today, but after the last meeting, I asked John and Carrie to figure out a way to put together a quick policy, which they did, email it out to the committee members, and everybody is comfortable with it. I could have brought it to the meeting today, but I wanted governance to sit one more time in a room together and challenge each other on the draft. It is rock solid. I won't preemptively tell you what is in it, but I certainly expect we'll all see it next month for approval. Questions or comments?
Well, I'll add on that, Jim. You know, we have a lot of boards on the county, and it is difficult to find people that first want to serve on that board, and it's a double plus if that person happens to be qualified in that specialty. That's always great, but I acknowledge, you know, how important it is to try to engage the public, B, to get on the boards, and then B, to provide public comment. If there's something you want to say about a particular, like Riverside, that they come and show up and tell us.
Yeah. We'll bring the updated policy to the board eventually next month, I assume. But it isn't updated. It's not new. We've always had a policy procedure on public comment. The last time it was updated was 2020, I believe. And so we've now just gone ahead and made some tweaks with new leadership and staff and new boards so that we're all on the same page going forward.
Other comments? Hearing none, a motion to accept the minutes.
So moved.
Second. All in favor?
Aye.
Opposed, same sign. They are accepted. Any old business to come before the board today?
To say on that public notice, it's always a good reminder. Our viewership on YouTube is increasing. And so these public meetings, the recordings, they're out there for everybody to see. It's not just my mom anymore. There's other people who are out there watching what we have to say. So, and that's a good thing. Public engagement, as Commissioner Moore said, is always a good thing.
Do we know how many are watching, checking in on meetings? How many per month or?
It's between 20 and 30.
Really?
Yeah, depending on the meeting. Yeah. At least that many views. I don't know, I can't tell how many of those are staff and,
Board members going back.
board members trying to figure out what we talked about. So, but
Making sure we didn't say something inappropriate.
We start, Ken, are we starting to see revenue yet out of that YouTube usage?
Yeah, but that's gonna, I'll be that 2 minutes.
can't call ourselves influencers yet.
Makes me ponder who we need then for board members. Libby Dunn, maybe, I don't know.
Okay.
That makes me think. I made a comment earlier about,
Signed up.
asked a question about vaccination per year for COVID and even influenza. And I'm looking for guidance because people ask me questions. I tell the people, I'm a scientist, I provide data. I can help you understand the data or recommendations, but I would never tell a person you should get vaccinated. That's outside my, that's not what I do. But I can't even provide some guidance if there are no guidelines available. That's disturbing.
Well, I think we can have, and Kristen's in the room with us this morning, and we can have our public health team share the latest and greatest vaccine guidelines, since there's been so much confusion and discussion.
Yep.
And we can get that out to you.
Any other old business to come before the board? And that's pole vault. Child Advocacy Center overview. Is that Kristen? Tricia?
Give me a second, I'll pull it up for you.
Where do I go? Yeah, probably. Good. Where you want to?
Yep.
Okay.
Yeah.
This is Tricia Loving. Tricia runs our Child Advocacy Center. She's our coordinator for it and by far the expert on it. And so we're gonna just ping pong back and forth and let you know a little bit about what we do and why we do it.
And particularly because this month, we've said is.
It's Child Abuse Prevention Month. And we'll talk a little bit about what we're doing. The Child Advocacy Center is the end result of kids that have experienced abuse. So how do we, as an entity that does the best we can to support families when they've dealt with that, how do we also help prevent them from ever getting to be physically Tricia? So.
Is the center a physical location or is it a program?
Both. Yeah, it's a program. And that's a great way to start. We're an accredited program. And there's 9 of us, I believe, in Montana. And so we go through a full accreditation process. And we're located in the other building right by WIC. And we have, I have a picture of it later on in the slide, but we have three different rooms that put together our advocacy center. So. Yes, 3. So first of all, the Child Advocacy Center, what is that? It's like Kristen said, it's unfortunately the end result when a child experiences either physical abuse or sexual abuse, or they can also be a witness to violence to come to the Advocacy Center. So the main thing that we do at the Advocacy Center is we provide the space for the child to do what we call a forensic interview. But we also provide services like advocacy, support for the whole entire family as a whole to kind of go through this process, whether it be the criminal process or just following the child through their recovery with therapy and all of that. And so the idea of the Advocacy Center is to come at the child as a whole with the whole team. And so they only have to come tell their story one time is the goal. And so with the Advocacy Center model, it reduces the amount of times the children have to talk, like I just said, and I'll go through what a forensic interview is. And it also increases the chances of successful prosecution for the offender. It's like the cleanest model to go through to get to prosecution. We work with multiple agencies to make sure the child's getting wraparound services. It reduces evidence collection errors, and then provides the family with ongoing support. You can go to the next slide. Yeah. So forensic, there we go. The forensic interview is what we call it. And that is a one-on-one conversation with the child and a trained forensic interviewer. And the interviewer goes through initially 32 hours of training to become a forensic interviewer. And then we have to do additional training on top of that, also peer review. So what it is a one-on-one conversation with the child where the interviewer is asking non-leading questions to get the child's story and unfortunately get the details and descriptions of the stuff that none of us want to hear. That's what our interviewers are sitting through. So the goal of the interview is to collect as much evidence as we can to get to the charges if possible. And so here in Yellowstone County, we have 14 interviewers, including myself. That's the most in the state that any advocacy center has. The majority of our interviewers are detectives. So thankfully the sheriffs, Laurel and BPD provide those at no cost to us. That's just part of their jobs to come over here and do a forensic interview. And so we have to adjust as an interviewer to each child to make sure it's developmentally appropriate for them and to just help guide them through sort of the event. The biggest thing you'll hear us say is, tell us what happened from start to finish. And then they tell us, and then we say, tell me, you know, you said this, tell me all about that. That's like the biggest thing in our language is tell me all about that. And so the interview is a recorded process and it's live feeded into one of our other rooms where the team sits. So the detective cannot do their own interview, but they are sitting in the observation room observing the interview live so that when the interviewer takes a break, they can come in, ask the detective, what did I miss? What do you want me to go back on? What do we need more details on? In the room is also myself, if I'm not doing the interview, the CPS worker, if there's a CPS worker, and hopefully the county attorney, if they have time, but they're very slammed. But the county attorney in there has helped a lot on a lot of cases to get additional information that we wouldn't really think about for prosecution. All of this, of course, is trauma informed to help the kid through this. While the child is going through an interview, the caregiver is in a room with Leandra, our advocate, who is working with the caregiver to talk about services, get the child set up for therapy. RiverStone provides a follow-up medical appointment for the child so that they can ask Dr. Littlefield any questions about what they went through, or the family can ask any, you know, if the kid needs birth control or do they need additional resources or referrals for medical needs. And then we also set up a process here in RiverStone that while the family's there, we can get them set up in therapy at RiverStone on site. So that has been really helpful to get kids into therapy right away, and we're not missing that gap when they leave here.
How does someone get to the Child Advocacy Center?
Great question.
Maybe we're going to address that.
No, that's a great question. So the Child Advocacy Center only accepts referrals from law enforcement agencies.
Okay.
And so it has to be an active criminal investigation. Yep. So this is the interview room. So you can see there's two cameras. There's one right there, and then there's one up on the ceiling. And we have to notify the children on recording that they are being recorded. So they know that, the family knows that. And so that's where we sit. If they're littles, we have a little table we can pull out. And, you know, we have some big detective guys that sit in those little chairs. It's pretty funny. And so that's where the interview takes place.
Perfect. That space, if you haven't been there, you're free to come up at any point in time. Come up, it's over in our Family Health Center. You walk into that room and you automatically just go,
it's all sound.
It's all soundproof. It's just gives you a very sense of calm as you walk into it. So it's a really cool place to be able to do that. A little bit about our Child Advocacy Center. We're doing some rearranging here in our in this building and stuff. And part of that rearranging is that the Child Advocacy Center is actually going to come over here. Right now, we're a little bit fragmented. Our observation rooms in one spot, and this is in another spot, our families in another spot. It's really confusing for families when they show up, where to go and what they should do. So we will be actually eventually, as we're going, moving into where the HR space is. So it's one area that they walk into. Everybody's in the same spot. It provides space for a distance that we need, but it's also one friendly space for our families to walk into, and not everybody has to know why they're there. They could just walk on in to the building. So we're pretty excited about that happening, and we've had some great support from our community to be able to make that happen for us, and also to upgrade our equipment and upgrade the way that we can share our information back and forth with our team. So Tricia talked about how we have a multidisciplinary team. Child advocacy centers are required to have a group of people that are involved in this. And I have to say, I haven't been involved in anything like this, of the commitment of the people that walk into this and what they work at. The people who come to their monthly meetings for that team are committed. They're there, they're engaged, they're involved. Their superiors, as we say, form our advisory council, and they're committed. They're there as to how we move forward. This is really, truly a community function, and it's really neat to see how we can come together as a community to make sure that the children who've experienced trauma are taken care of to the absolute best possibility that we have for them. So as she said, we do monthly case reviews so that those interviewers have a chance to talk to each other and build each other's skills. We have our monthly meetings that we debrief on cases to say where are we at, where are we going, what do we still need to do for this family. And frankly, some of it is just support. I walked into the first the MDT meeting that I came to and went, oh my gosh, this is not normal. What is going on here? Because the people who come there deal with this, and it's exhausting and traumatizing for them as well. So they use that meeting to really bond to one another and be able to just release. They talk about business, but they also have a time to debrief with each other. They also know who to call if they've had a tough interview, and to be able to do that. So it functions, it's not a business meeting by any means. It functions very differently and is actually kind of refreshing once you can understand the perspective of where it comes from and what they do through there. So I think we do a fabulous job. Our funding is very braided. Our funding comes via a VOCA grant that comes through the state that we apply for every couple of years. Our county attorney helps fund some of that. Of course, our staff is they live here at RiverStone, so they're cared for via, our insurance that we're able, and our benefits that we have here at RiverStone. So, and then our clinic really has the piece of it that we were missing within the community. The medical piece of it was taken on by us here at RiverStone to make sure that these kids are done. Our SANE interviews, which are those interviews that happen within 72 hours after a trauma happens, our Billings Clinic partners take care of that piece of it. So we really, as a community, have multiple people and multiple pieces and parts that kind of make sure that this happens.
And then this is just kind of an overview of the Advocacy Center and how many interviews we've done. So last year we did 213 forensic interviews on children. We see children ages 4 to 16. We actually had a very in-depth discussion yesterday at our MDT about 4-year-olds, because it's really complicated to interview a 4-year-old. It's more than just sitting down and asking them, like, what's your name? Like, it's a very detailed conversation. And how do we decide if 4-year-olds can have those conversations? But the majority of the kids we see are age 7 to 12. The majority are female. And the majority of what we see is sex abuse. And I believe last year in those 213, only one was an unknown offender. The rest were known to the child. That's the most common thing you see, is somebody that they know and they trust that are offending on them. That's it. Questions?
Follow up on Carol's question as far as how children get there. Are you restricted to only getting referrals from law enforcement? I'm wondering, I would think like a teacher or a neighbor or even a parent
Yeah.
would have concern. Do they contact you and then you refer them to law enforcement, or how's that?
Ideally, how the process would work is if a child discloses to, say, a teacher, the teacher calls and reports it to CPS. CPS and law enforcement work together to determine the next steps, and then law enforcement sends the referral. So it's all a very intertwined system, but it has to come from law enforcement.
When you're interviewing a child, how many adults?
With the child, just the interviewer child, that's it.
So everybody else is listening from the room next door.
Yes, not
Anyone else?
caregiver, nobody is allowed to listen unless you're part of the investigation.
Right.
So like, I'm the director for this. I can't go sit and listen to this because I have no reason to know that information. I don't attend. I attended just so I could kind of understand the process, the very beginning of that MDT team. I'm not intricately involved in this. I deal with the finance piece on the other side of it and the general operations. I don't have a need to hear that, and I don't have a need to be involved. So it's really a need to know basis. People sign in when they come. They know that they can't share I mean, it's a very restricted process.
And then we have a recording system and we're gonna update the recording system so that it's more secure. But right now what happens is it's recorded. I put it on a USB, law enforcement takes the USB and puts it into evidence. And that's sort of how and then our system deletes it so that we're not keeping those here. The one that we want to get, it will be through the cloud, a secure system where I can just send it via email so that there's here's a USB. I trust you to take this USB downtown and not drop it anywhere. Yeah.
What is the background of the interviewer? What is your role? Are you a social worker? Is it somebody who's gone through training?
Yeah, so the majority of them are detectives, and then they have to go through that training. Since I've been on board, I came from CPS as an investigator. I was there for 5 years, so I've been trying to get those people to come over here too. So we now have 3 CPS interviewers, and all 3 of them are female, which is phenomenal because when I came on board, I believe we had maybe 1 or 2 female interviewers. And there's sometimes the child says, like, I'm not talking to a guy, like, I'm not going to do it. So then we really had to scramble to figure that out. So the majority of everybody that are doing the interviews has either law enforcement or CPS background.
And the CPS background, social work, or is it like the educated?
It's a
trained
person. Yeah, bachelor's degree and then all through training.
Megan, anything you wanted to add?
No, I mean, our CAC team is really amazing. We still have, I think one thing that is important to recognize is that only a fraction of child maltreatment cases ever make it to the CAC. You know, there is a lot that, and I think we learned at the last conference, Tricia, when was the average age of disclosure for child sexual abuse? It's like in your 40s or 50s.
Yeah.
Yeah. So I'm sorry, go ahead.
When I do a presentation to like the community, like Breakfast Exchange or any of that, I actually use a picture of the Metra because it's 1 in 10 children are experiencing child abuse, and that within Yellowstone County, that's enough to build a Metra. But they're not disclosing until they're in their 50s is usually the average age. So it's very prominent in our community, and then our children just don't know about it.
These are long drawn out cases too, for these families that they do, average of at least 3 years. And so our advocate stays involved with that family just as long as they want to be involved and support them. And it may be every 2 or 3 month check-in or that kind of situation. And I know the other piece that we're doing and really promoting as it's Child Abuse Prevention Month is Tricia works with a group from the MDT team and advisory to help do a better job of community about child abuse prevention. And we've gotten out in several, we have some coffee shops that coordinated with us that are selling blue drinks for the month. And we've done some of that. And so our goal is next year, really starting in October and doing a very coordinated, really community-wide how do we gather in our schools and our daycares and our parent groups, and how do we do that and do a really broad educational effort of it, because really that's what it's all about, is how do we educate and prevent them from ever seeing us.
Yeah, so our team does an amazing job, because the other thing that I think is important to recognize is that only a fraction of cases really ever get to prosecution, unfortunately. And so the CAC is so much more, the forensic interview, and all of this is so critically important, but then the continued value that they bring to supporting that family through the resolution of the case or until the case is dismissed is really critical, and they're amazing. You should go visit them.
Your question.
Just comment real quick. We've been hearing about this for a while at the board level, but getting a more thorough understanding of it is fantastic. I'm really proud of the organization for being very aggressive on this particular issue. And somewhat, I'm on track a little bit with something slightly different. At a separate board meeting, different organization. Just a couple of weeks ago, we had a presentation from a state legislator from Billings, and gave us some numbers on things that I think most of us are largely unaware of. How many children are sold in Billings? Sold, you can buy children. I think it wouldn't be bad if we had some of these numbers to make us aware of how serious this problem is and how widespread. But I'm glad that we're doing what we can to help out where we can. I think it's part of the organization for that. Thank you very much.
Kristen and Trish, you guys want to talk about the service area that you're serving? So where are your referrals coming from?
Oh, primarily it's Yellowstone County.
Yeah.
But we also do forensic interviews for our neighboring counties that don't have that option to do that kind of stuff. Trisha actually does primarily most of those. So you'll have a detective from maybe Muscle Show call and say, hey, I got this kid. Or the other piece that we have is that we have children who are maybe living at YBGR or one of our other residential places here that are from out of state, that obviously they can't do a forensic interview anywhere else. So they will bring them here, and then we can take care of those as well. Anybody else?
I don't think it's part of your program, but like for CPS, like from the school system point of view, we make a report. You don't know what the algorithm is after that. So if we make a report to CPS, and then we make another report next month, and then we do another report. Like, it's frustrating on our part. We don't know what happens to that report and where it goes, but it is frustrating when we, report the same family member. And then they report, then somebody else reports something that's really invalid. They make a big deal of it. I don't know. From my point of view, I think if the school nurses can be more educated on that, and the teachers. I don't know.
If you have a way for us to do that, let me know. But we have a very hard time getting into the schools.
Okay.
We had, when I first started here, we had a huge meeting trying to figure out how to educate the schools.
Yes. Okay.
So Gordon Klasna from School District 2 has joined our advisory recently. So we're Gordon Klasna has joined our advisory board, which is really that intent to try to do some collaboration between the schools.
Well, I know every year they're trying to do ME training, to get credits to meet your requirements as teachers and other professionals. It'd be a great time to set something up with that. Thank you.
Yes, you had great growth from 14 to 15. You saw a lot more interviews. Do you have a maximum? Or are you more close to maximum?
Nope. And it depends on the week. Like this week I have 4 today, 4 interviews today, 2 4 or 5, so 6 this week, and then some weeks we'll have like 1 or 2. So it's weird how it goes. I don't know what it is. I don't know if the detectives just sit on it for a second because something big is going on in the community, and then all of a sudden I get a rush. But I think, yeah, like yesterday I got about 6 referrals, so next week will be busy.
But you have plenty of capacity.
Yep.
So,
It sounds like there's plenty of issues, so.
Yeah.
So do you do all the scheduling then, in terms of bringing all the pieces together?
Yep. Yeah, the detectives reach out to the family initially, describe what a forensic interview is and say Trisha's gonna be calling you. And then I call, try to coordinate with detectives, CPS, families, all the time. That works with everybody, so. Yesterday, we had a really long discussion at our team meeting about emergency forensic interviews too, and what those are and when we utilize that. There's been a couple since I've been here. So we're trying to figure out what those are and when we utilize that. I got, after one incident, I got, my badge can now get me in on New Year's Day at 8 a.m. To come in and do a forensic interview. So since I've come, I've allowed my access to do that because I know how important it is to get kids here when something like that is happening, as opposed to taking them to the police station where it's scary or they feel they're in trouble. So
they're being a little bit modest. They do their work behind the scenes, but when Kristen says neighboring counties, also take like neighboring counties, meaning North Dakota, South Dakota. We are the last stop as far as an accredited CAC, but from here to the Dakotas.
Yeah.
And so all of Eastern Montana is coming here potentially for this resource. And as you can see by the numbers, it is unfortunately a growing need.
Yeah.
thank you.
Thank you both.
Thank you.
Thank you.
Wonder how the MFMR match went this year.
Well, it's funny you should ask, Jim. Let me tell you about that. And Dr. Littlefield, feel free to chime in as I go about this slide deck. So Dr. Brand shared with us, our MFMR program director, couldn't be with us this morning, but I asked, hey, how did the match go? And who will be joining our team here at the Montana Family Medicine Residency Program coming up? And so I'll share that deck with y'all. I can get it to work. Very. There we go. So our match 2026, we had 736 applications, 360 applications in the supplemental match. So the match week goes from March 16th to the 20th. And if residents aren't matched in the initial match, they choose us, we choose them. There's a supplemental process called SOAP that we go through. And unfortunately, we had to go through that SOAP process again this year. We had 120 interviews, the team did over 2 weeks. And then within 2 days, they did 50 additional interviews during that week. So really worked hard this year to get folks in the door. And so ultimately, as an end result, after all of that work, we matched 8 residents here in Billings and 2 in our new rural residency program up in Miles City. So nationally, you're seeing family medicine applications down about 5 to 10%. Residents are going into debt. Their loan repayment is being questioned at the federal level potentially. And so you're seeing medical students choose other specialties and other areas of medicine where they can potentially get better payback. And so family medicine programs have also increased in the number of supplemental needs that they're not matching in the initial match. So they have to go into the supplemental match more often. And so, for whatever reason, the student perception of family medicine continues to decline. And Dr. Brand and our residency team in the Montana Family Medicine residency are doing everything possible that they can to market family medicine as a great place to work in medicine and make a difference. But we're also seeing at the larger national level, other programs across the country, on the coasts in particular, in larger cities, the University of Maryland's, the Cornell's, the Mass General's, the bigger hospital systems in our larger cities are getting funding for creating rural residency programs and family medicine residency tracks. That is, taking away the potential for, folks to come to rural frontier locations to practice medicine. So a lot of things going on, a lot of things working against us. But, what worked is the fact that this team, this MFMR team here locally, has a really good process in place for interviewing residents, using technology to get them here virtually. Unfortunately, we don't have a lot of folks that come in person to see us because it's expensive to travel to Billings from different places. So that's been a consideration. And every time I get the air service survey from the Chamber of Commerce, one of the very first things I put down is the fact that our airfare issues and our lack of flight availability is impacting our medical hub's ability to attract the economic drivers we need to make Eastern Montana successful. And I continue to harp on that. And a couple of years ago, we even wrote a letter to a couple airlines directly and said, we could really use your help in getting folks here to one, interview for positions, so that also see that this is a great place to work in healthcare. So they continue to work through the barriers of interviewing. A lot of virtual interviews, and those virtual interviews are taking a lot of time. They're doing over 600 interviews, but those folks aren't choosing us for whatever reason. And I think it's hard to see pictures of Billings and to see Billings virtually and to see Eastern Montana, on the computer and everything that you can Google. But it's when you get here and when you see the people, when you meet the team and you see the environment that you're going to work in, that connection is made better with students and potential residents. So trying to get folks here in town and primarily trying to get Montana applicants. Anything you wanted to add there, Dr. Littlefield?
No, I think just the key point being, I think that the biggest impact that we have seen, in addition to the national trends of just decreasing applicants to family medicine, has been our shift to virtual interviews during COVID. I think that when we get people on site, meeting our faculty, seeing our facilities, seeing the opportunities that they have at the two hospitals that we have in town. I think that's the biggest decision-making factor. And I think that we have just seen a big impact with you can only learn so much when you do a virtual interview. And so that's the challenge that we're trying to address.
So Megan, do we have a video to send them about how great we are?
We do. We actually, a couple of years ago, because during COVID was when we really was when all residencies shifted to a virtual format. Before that, there was no virtual format for interviews. During COVID, when we were forced to do that, we actually had our comms team develop we had a drone that actually even went through the clinic to the different, we went over the city of Billings. We went through the clinic and we actually would have someone sort of give a virtual tour using this video going through the clinic.
And, I think I've mentioned it here before, and to Carol, to your earlier point about the rural health transformation programs, one of the pieces of our HTP is that Department of Labor and Industry is getting a boatload of money to do workforce pipeline building, and part of that is recruitment and marketing. And one of the things that we were working on prior in the Alliance and some other healthcare partners in town with Big Sky Economic Development before they kind of went through their changes was we were going to start a marketing campaign on why Eastern Montana Billings Healthcare is amazing and you want to work here. And they had a firm lined up. The firm had done something similar with the Mayo Clinic and getting people to move to Rochester, Minnesota, and different places across the country. And they had some success. And their changes at economic development and the funding fell out of the bottom of that. But that's what we've been talking to DLI on about now from a state level, and primarily in Eastern Montana regional level is we need that. We need that marketing campaign. We need the videos. We need to be able to show off Billings rather than the drive that you see coming in 94 into Lockwood. But what are we really? And why should you want to be here? So that's going to be a big part of this rural health money, hopefully, is marketing different careers and pathways.
And because it's 600 miles to a bigger medical center, we have really gotten good at doing most things.
Yeah. And it's one of the things, I go back to my VA days and the University of Maryland School of Dentistry. All the dental students wanted to do a rotation at the VA Medical Center because they could do it all and they saw it all, right? And so we've got to get good at saying, hey, you can do it all and see it all right here in Billings, Montana, because we have the resources and we've had to build those resources to meet the needs of a rural frontier community. So we'll see.
Yeah, and I'll just quickly add to that. So I did my training. I'm actually med peds. I'm not family medicine. I'm dually boarded in internal medicine and pediatrics. But I did my training, University of Chicago, big, tertiary quaternary institution. What I think is so powerful about our residency program is that it's a community-based program, which 1% of medicine takes place in these, big tertiary quaternary, hospitals. The majority of healthcare in the United States is not in those major facilities. The power of our program is that it's a community-based program, but exactly what you just said, the fact that there isn't a major hospital, a major academic hospital in our area. Our hospitals here are really, we don't do transplants. There are some things that we really have to send people out of state for, but we do everything else here. And so the residents get trained in how do you work in resource limited environments, and yet they get that intense training in the hospitals of what subspecialty care really, really looks like and what our state has to offer. And so, and I think this is more than what you're able to get in Missoula. I think that our hospitals here are, have a lot more subspecialties present than they do in Missoula. And so I feel like we need to really try and help people to understand how they get the best of both worlds when they come, to our program.
For sure. So, who's who? Let's talk about, the class of 2029. And I'll go through their personal bios real quick and share a better overview. But this is one of the things that we do, Dr. Brand does with residency faculty and our current residents. It gets everybody together and has a reveal of who's coming to join us and why did they pick us. So these are our first year residents coming in to the Montana Family Medicine program this year. Megan from Roswell, New Mexico, will be joining us. Jordan is coming to us, currently up in Sydney. She's joining our rural training track up in Miles City. So it'd be great to have a Montana born and raised physician who wants to work in rural Montana. So really glad to see that. Matt is coming to us as a non-traditional resident. He did some chiropractic medicine, rehab, he worked in engineering, nutrition, correctional medicine, functional medicine, and hopefully now he's found his passion in family medicine. So he'll be coming to join us. Naj is originally from South India, coming to us from Florida. So coming over from the East Coast, will be working with us. Kevin, originally from small town in Colorado, will be joining us. Ash is coming. I forget where Ash is from. Melinda from Charlotte, North Carolina, and the Virginia School of Osteopathic Medicine. Williams coming from, Matt is coming from Chattanooga, Tennessee, finishing up a pathology residency in Tampa, Florida. Basil from New York City will be coming to us. Cheyenne from Western Canada moved to Colorado with Colorado State. Kansas College of Osteopathic Medicine. Mathili from Southern India, another non-traditional student coming to us. She's actually in a residency program transitioning to family medicine. So she'll be incoming second year resident. And so there you have it. Our 8 traditional residents or first year residents are 2, Jordan and Megan, joining our rural training track up in Miles City, and a new second year resident coming into the program. So just happy to continue our educational mission and focus with MFMR. Anything to add, Megan?
No, did this include, we just had a resident join us this week who was transferring from another residency. And so we also have her, she's joining, I don't think she's listed on here though, but she's joining the first year class. And so we'll be finishing, she had started her residency at another residency that actually has closed. And so they frantically were trying to find placements for all of their residents. And we accepted her into our program, and she's just getting started this week. So we have another new person to join our pack.
This is a very eclectic group.
Yeah.
I like diversity, sitting around the table and solving problems.
Yeah.
It must be wonderful when they're all sitting around the table trying to
That is one good thing that the MFMR team has seen over the past 2 years is the just diversity of thought and training pathways and where folks are coming from all over the country. Different backgrounds, different nationalities, coming to Montana to find their passion. So it's good to see. Anything else for the good of the order?
Any comments from board members regarding the meeting today? Feedback? Hearing none, we're adjourned. Thanks, everyone.